Sarah is a prime MIP woman, 41 gestation, and allergic to penicillin. Her identified risk factor includes having Hep C positive and screening low HB level since booking at 109 HB at booking, and a retest showing a level of 90 HB at 28 weeks gestation. She also have identified repetitive UTIs during her pregnancy. Okay. Question 1. How will I assist Sarah to complete her birth of her baby? So Sarah is fully dilated and it is difficult for her to birth her baby's head. It is identified that she may have shoulder dystocia. Right, initially I would press emergency call for midwives and obstetrician and pediatrician to attend the birth. And I will quickly explain to Sarah and her partner what is happening, and that they will receive the full explanation once the emergency is over. I will then provide a quick handover to the medical staff, ONG doctors, midwives, and pediatrician regarding Sarah's progress during her labor and until then. The registrar will then observe for episiotomy and attend one, and I will assist Sarah into a recumbent position and remove the bottom half of the bed and support Sarah's thigh into a hyperflex position, which is also known as the McRoberts, to increase the pelvic floor room for the helper maneuvers. I would also allocate one midwife to be on the other side, attending the same thing as I am, by assisting Sarah's thigh into a hyperflex position to allow more room into her pelvic. The next step would be allocating another midwife to document down the times of each procedure. That is the time of episiotomy, and noting down the time of Sarah getting into a hyperflex position, and also the time of attending suprapubic fundal pressure for the ONG. The next step would be assisting the following step would be, if the suprapubic fundal pressure failed, then the ONG registrar can initiate enter maneuvers, which consists of internal rotation. This is also known as Reuben 2. And if that doesn't work, to rotate the baby's anterior shoulder under Sarah's symphysis, then the wood screw maneuver is applied. This is applied by the ONG doctor using two of his or her hand to disimpact the baby's anterior shoulder. If that doesn't progress, then the following procedure is the reverse wood screw maneuver. This is used to rotate the baby's shoulder into the opposite direction. This is attended by the ONG registrar, and that was successful. So the following step was the ONG doctor removed the baby's posterior arm. I assisted Sarah onto all-4 position. This is also known as the Gaskin maneuver. This position allows the baby's shoulder to dislodge while Sarah was changing position. The baby was then delivered at 15:45, and I documented each procedure that occurred during the delivery of the baby's body. Question 2. How do you think the baby will be at birth, and why, and what will you initiate in anticipation? Alright, at 12 o'clock, I observed the baby's well-being through continuous CTG monitoring as per protocol. That is, documenting the baby's well-being in the progress notes every half an hour, as well as writing up the CTG stickers every hour and getting the CTG checked with another midwife. I then I also organized a resuscitation trolley to be in the room, and also set up the delivery trolley prior to the delivery. At 2 o'clock, I anticipated the shoulder dystocia occurrence. Consisting of incoordinate contractions to mild and irregular contractions. Sarah also showed signs of prolonged second stage of labor because it took her 1 hour 20 minutes to finally deliver her baby's head. And another risk factor of shoulder dystocia that I anticipated was the use of oxytocin augmentation. At 15:35, I called the pediatrician and organized them to be at their birth. Following the birth of Sarah's baby, the cord was clamped and cut, and I brought the baby over to the resuscitation trolley for the pediatrician and assisted the pediatrician by stimulating the baby immediately after birth. I also checked the APGAR score at 1, 5, and 10 minutes, and this was done by pressing the timer on the resuscitation trolley. And the APGAR score is calculated by the heart rate, respiratory effort, muscle tone, reflex, and color. The pediatrician then initiated resuscitation at 15:45, and I assisted the pediatrician by drying and stimulating the baby, positioned the head and neck to open the airway, and provided warmth and assess the baby's OB, including respiratory rate, heart rate, and observe the baby's color. The baby heart was at 80 beats per minute at 15:46. So then the pediatrician commenced positive pressure ventilation. This is also known as PPV at a rate of 40 to 60 breaths per minute for half a minute. There was no improvement 30 seconds later, so the pediatrician commenced chest compression at a rate of 3 compression to 1 breath. At 15:47, the baby's heart finally reached 110 beats per minute, and the baby was breathing spontaneously without assistance. Question 3. What other concern do you have for Sarah's well-being, and how will you help her immediate following birth? 1547. Shoulder dystocia increased the risk of PPH, and Sarah's risk of having PPH because she was not contracting regularly during the intrapartum stage. Another risk factor in which I anticipated was Sarah having an episiotomy and vaginal tear. This also increased the risk of PPH, and to avoid this from occurring, an episiotomy can be performed under a controlled environment by an experienced medical officer. Another big risk factor for Sarah was her low HB level since booking, because she started with 109 HB at booking. The level further reduced to 90 HB at 28 weeks gestation. If Sarah was to have a PPH, she would be anemic and suffer from maternity blues. She would have reduced sense of well-being and also have a higher chance of suffering from postnatal depression. So 1549. I anticipated to avoid PPH by controlling her HB level from preparing an injection of 10 international unit syntocinon and administer that injection into her thigh when her baby's anterior shoulder was delivered. I also prepared a bag of 1 liter Hartmann solution mixed with 40 units of syntocinon before her delivery, and this was primed on a line and set up in an electronic pump ready to be given when needed. At 1400, this was during the intrapartum stage, I also anticipated from Sarah having a PPH by organizing the O&G doctor to collect her blood for a group and hold test. This would determine her blood group, and if she needed a blood transfusion, then her blood group would be available, and this will lead to the following step, which is organizing and ordering bloods for Sarah. This would be given to her should she have a PPH. Another final thing that I am concerned about Sarah's well-being immediately following her birth is her emotions. She would be anxious and shocked from the delivery and procedures. So I would organize a formal debrief discussion with Amy and provide her with the overall explanation of the procedure, and make sure that she is not feeling guilty, angry or depressed after delivery, because the birth was a traumatic experience for both her and her family. And that would be my emergency care for Sarah. Thank you.